Childbirth is an exciting and rewarding experience. When contractions begin, they usually last for 30 seconds to 1 minute and occur at 2 to 3 minute intervals. Contractions less than 2 minutes apart are a sign of imminent delivery. Mothers that have delivered previously can usually tell you of imminent birth. These women are commonly straining and have an urge to go to the bathroom. Whenever possible, it is best to deliver at the hospital where both mom and baby can be cared for in clean, warm, well-lit surroundings. In cases where the baby is crowning, it is generally advised to stay on scene and deliver, then transport. Once crowning is present, the baby is very far into the birth canal and may deliver en route, which is much more stressful for everyone given the tight quarters and movement in the back of the ambulance. Assisting with a childbirth begins when you arrive on scene. Start your evaluation of the mother and determine if you will be delivering on scene or transporting in an effort to reach the hospital before delivery. Ask the following questions. What is the due date? What prenatal care have you received? Have you had any complications in your pregnancy? Is this your first pregnancy? Describe your contractions. How long and how far apart are they? Have you had any vaginal discharge? What color? How much? Have you had any bleeding? If so, how much? How many pads have you soaked through today? Has your water broken? Do you have the urge to defecate? Do you have the urge to push? The questions and upcoming physical exam are personal and private in nature. Be respectful and accommodating to the patient's privacy by excusing unnecessary personnel from the area and doing your best to keep her covered. The mother may want the father or a friend to remain with her. You should take a sample history and baseline vital signs. Watch for hypertension, which could indicate a serious complication called preeclampsia. Contractions can be felt by placing a hand on the patient's abdomen. However, contractions are usually painful, and mom will generally let you know when they begin and end. If contractions are less than 2 minutes apart, consider staying on scene to deliver, especially if this is not her first delivery. Place absorbent material, such as towels or chucks, on the ground. Move the mother into a supine position, knees up, for examination and possible delivery. Position the mother on the towels or chucks to absorb the blood and fluids expelled during delivery. Drape the mother for privacy. Remove clothing that obstructs the vaginal opening. Examine the perineum to look for signs of crowning, that is, the baby's head presenting through the vaginal opening. If crowning is present, prepare for immediate delivery. Take BSI precautions, including the application of sterile gloves from the OB kit. Clean the vaginal area with antiseptic towelettes. Wipe in an anterior to posterior motion to keep from bringing fecal matter into the vaginal area. Using clean sheets or towels, drape the delivery area, leaving the vaginal opening exposed. Begin to coach mom to push during her contractions and breathe during her rest periods. As the baby's head presents, support the head and apply slight counter pressure around the vaginal folds to prevent an explosive delivery from tearing the vaginal area and perineum. Make sure the amniotic sac surrounding the baby has ruptured. If not, gently puncture the sac with your fingers, removing it from the baby's face. Once the head has delivered, quickly suction the baby's mouth, then nose. In some deliveries, the umbilical cord will be wrapped around the baby's neck. If this is the case, gently try to slip it over the baby's head. In a scenario where you cannot free the cord from around the neck, clamp the cord in 2 places and cut between the clamps. After the head, the anterior shoulder will deliver first. As the anterior shoulder delivers, apply gentle downward pressure to get the shoulder out. After the anterior shoulder, the posterior shoulder should deliver easily. As the posterior shoulder delivers, you can apply gentle upward pressure to free the shoulder more easily. Support the trunk and feet as the rest of the baby delivers. Be careful, babies are very slippery. After delivery, dry off the baby and continue to monitor the airway, suctioning as needed. Wrap the baby in blankets or swaddling cloth to conserve body heat. Hypothermia in infants is a major cause of infant distress. Immediately assess the baby after birth and 5 minutes later, monitoring breathing, heart rate, crying, movement, and skin color. These are the elements of the APGAR score, and while EMTs are not usually required to know all of these elements, the physician may ask you questions in order to acquire an APGAR score for their records. Keep the baby at the same level as the vagina until the umbilical cord stops pulsating. To cut the cord, place an umbilical clamp 8 inches from the baby. Place the second clamp about 2 inches from the first. Cut the cord between the 2 clamps. Note the time of birth. The mother may want to immediately nurse the baby. This will help control any postpartum bleeding, so encourage her to do so. Even holding the infant to her chest will usually stimulate the letdown of milk and contractions needed to tighten the uterus and stop postpartum bleeding. Placental delivery usually begins several minutes after delivery of the baby, although it may take as long as 20 minutes to begin. Do not pull or tug on the umbilical cord. The placenta will expel on its own. Remember to save the placenta in the plastic bag provided, as the receiving physician will want to examine it. Monitor the mother and baby during transport to the hospital. In some births, the baby will not begin breathing. If the baby is not breathing after 30 seconds of stimulation, resuscitation will be necessary. The EMT should focus on these measures in this order: drying, warming, positioning, suctioning, tactile stimulation, oxygen, bag mask ventilation, and then chest compressions. Of course, any infant who requires resuscitation should have the benefit of ALS. Attempt to meet with an advanced life support unit en route to the hospital. The mother may continue to bleed vaginally, but usually no more than 500 cc's. If excessive bleeding occurs, sanitary pads may be placed over, but not into, the vagina to help control bleeding. Monitor for signs and symptoms of hypovolemic shock, such as tachycardia, pale skin, and altered level of consciousness. If any of the above exist, treat for shock and rendezvous with ALS. Massaging the uterus through the abdomen often stimulates uterine contractions, which stops the undesired bleeding. There are several complications to childbirth. Here's how to handle the most common. Breech presentation. This occurs when the baby's buttocks or feet present first, instead of the head. Position the mother head down with pelvis elevated. Support the body as delivery progresses. Provide high-flow oxygen to the mother, and begin rapid transport immediately, as the mother may need surgery to get the baby out. Prolapsed cord. This is the condition in which the umbilical cord presents first instead of the head. As delivery progresses, the cord will be caught between the head and vaginal wall, obstructing blood flow to the baby. Position the mother head down with her pelvis elevated. Insert several fingers into the vagina to keep pressure off the umbilical cord. Cover the exposed cord with a moist, sterile towel. Provide high-flow oxygen to the mother and begin rapid transport, as surgery may be required to save the baby. Limb presentation. This occurs when instead of the head crowning, you may see an arm or leg. Again, position the mother head down with her pelvis elevated. Provide high-flow oxygen to the mother and begin rapid transport in the event surgery is needed to extract the baby. Meconium. This is amniotic fluid that is green, yellow, or brown in color. It is an indication of fetal distress and that the baby has had its first bowel movement while inside the mother's womb. When meconium is present, suction the baby aggressively before stimulation. Mouth first, then nose. Monitor closely and provide resuscitation if necessary. Meconium babies often have respiratory compromise and may need oxygen, if not bag valve mask ventilation.